Good morning, everyone. And today, our topic of neurology is peripheral nerve disease, or which is also called as peripheral neuropathy. So, as it says, like peripheral neuropathy is the disorders of peripheral nerves. And to show you what are the peripheral nerves, you can see like the peripheral nerves include the dorsal, the ventral nerve root, the dorsal nerve root, the dorsal root ganglion, and then the spinal nerve, plus when it comes to the nerves, so of course all the brachial plexus, lumbosacral, sacral plexus, cranial nerve problems, except cranial nerve 1 and 2. Why? Because they are not true cranial nerves, and I had explained this thing before, why they are not true cranial nerves. So now, of course, like um, it means like all the sensory, motor, autonomic, or mixed nerves, we collectively give them the term as peripheral because they are not the part of central nervous system, so that they are the part of peripheral nervous system. Or simply, it indicates that the disorder is outside the central nervous system or outside the brain and spinal cord. Now, what's the importance of this topic is peripheral neuropathy affect up to 8% of adults, and the incidence of this condition increases with age. Um, now, a lot of what you can say basics will apply here, and we have to see, for example, like how we go, we take the history, we do the physical examination, and then we go for the investigation. So you can see over here, for example, uh, there are large fibers, there are small fibers. Large fibers are those which carry the fast sensations, or you can say the touch, vibration, proprioception, and things like this. Small fibers are those which carries pain and temperature sensations. So you can see over here, they are showing you the distribution of different type of uh, losses of the function of the nerves. Okay, at this stage, of course, you will not understand, but like after listening a little to this lecture, of course, you would understand. And I will bring the slide again. So now why I'm again showing you this again, like just to tell you the basic thing, like the large fiber neuropathy will lead to the posterior column sensations will be gone, or you can say the vibration, proprioception, and what you can say fine touch, and the small fibers when they are gone, of course, like there will be the pain and temperature sensations will be gone. And now, if you know like the function of the small sensory fibers or the large sensory fibers, and when the motor part is involved, of course it will result into weakness. So see, when we take the history, of course, like I will tell you the causes of this peripheral neuropathies, and then when we will do the examination, we see the distribution, as well as we see we want to see what type of sensations are lost or what type of weakness is there, to reach what you can say, um, to some conclusion, like the patient is having what kind of neuropathy. uh, and now peripheral neuropathies are very common, and they can be as a cause of many conditions. But before that, now like again they are showing you something, a spinal cord with a peripheral nerve and with a muscle. things. So focal or multifocal diseases affect one or more nerve roots and spinal nerves, nerve plexus, and individual peripheral nerves. It is called as mononeuropathy. Simply, here I want to discuss few terms to start with. So you can say classification, how we classify the things, and then we will discuss each thing one by one. So few things which you must understand is one is called as mono, means one, radiculopathy. Okay. So what is monoradiculopathy? Simply this one, like one of the nerve root, radiculopathy, nerve root. And now you know what is nerve root, right? So one of the nerve root is involved. We call it as mononeuropathy. Um, for example, if you know, there is something called as herniated disc, and I will show you over here. For example, like in the cervical or in the lumbar region, when some of the disc is prolapsed and it is causing pressure on the spinal cord, you can see over here the pathology, right? So of course, like in this case, the patient will be feeling pain, as well as we call it as radicular pain, as well as the nerve which is coming from here, that can be compressed, and of course that can lead to the sign and symptoms. A very very common thing, guys, which I think most of us we know, is called as sciatica. So in sciatica, what's going on? Like the nerve is compressed, right? The sciatic nerve is compressed. So that is called as monoradiculopathy. Now, one of the term is called as polyradiculopathy. Now, poly, again, rest everything is same, just it is many. So, of course, like when multiple nerve roots are involved or nerve root lesions are there, we call it as polyradiculopathy. One of the example of that thing is quadra equina syndrome. Now, what is quadra equina syndrome? Again, in this one, multiple lumbosacral roots are getting compressed, and we call it as quadra equina syndrome. I think rather I explained this thing before, what is quadra equina and what is conus medullaris, right? So simply, quadra equina syndrome is one of the example of polyradiculopathy. One of the thing is called as plexopathy. Now, what is plexopathy? Simply, uh, there are nerve plexus, for example, brachial plexus is there, lumbar plexus is there. So when some sort of problem or pathology or deficit match the distribution of the nerve plexus, we call it as plexopathy. For example, there could be brachial plexopathy in which the brachial plexus is involved, or there could be lumbosacral plexopathy in which lumbosacral plexus is the one which is involved. So uh, now we know that there is something called as Erb's palsy or Klumpke's palsy. So what happens in Erb's palsy, that uh, like I want to show you brachial plexus. Um, wait, I want to give you an example of brachial plexus. Brachial plexus. So now you can see over here, this is brachial plexus, right? So now whenever what happens is, brachial plexus, it originates from C5, C6, C7, C8, and T1. So whenever there is pathology or deficit in C5 C6 nerve root, uh, we call it as Erb's palsy. Whenever C8 and T1, the lower two, are involved, we call it as Klumpke's palsy. So see, C5 and C6 basically supply the shoulder and the upper arm. So they have lower motor neuron type of symptoms. See, lower motor, not upper, because it is now peripheral, not central. So they will be having lower motor neuron type of lesion in the shoulder and the forearm, where as C8 and T1 involves supply the forearm and the hand. So in Klumpke's palsy, what happens? They have lower motor neuron symptoms in and plus sensory symptoms in forearm and hand. Okay, of course, like this, plexopathy can be due to trauma, can be due to tumors, can be due to radiations and things like this. And same thing with lumbosacral plexopathy. So this is called as plexopathy. Then there is a term called as mononeuropathy. So again, mono, one, and neuro is nerve. Now it is not nerve root, rather it's a nerve. So mononeuropathy is simply when someone have a single nerve deficit. For example, if you know, the most common example of this one is carpal tunnel syndrome. So see, one nerve is involved. So what happens in carpal tunnel syndrome is the median nerve get compressed at the wrist. So the patient, they present with wrist pain, they present with paresthesia in the first 3.5 digits, uh, and things like this. And we do Tinel's test or Fallon's test for that. So carpal tunnel syndrome is one of the example of this thing, but there is tarsal tunnel syndrome, and there are many other examples for this thing. Mononeuropathy, one of the example, a famous one, is also called as Bell's palsy. So what is Bell's palsy? It is, uh, you can say, like, it is the most common cranial neuropathy, because facial nerve is a cranial nerve. So what happens in this one? There is involvement of the facial nerve. So same like this, like I gave you the example of carpal tunnel syndrome, or I gave you the example of facial nerve palsy. There could be ulnar nerve compression. There could be radial nerve compression. For example, the ulnar nerve most commonly get compressed at elbow joint, and radial nerve most commonly get involved or get compressed or get any sort of trauma in the spiral groove of humerus. Obturator nerve, peroneal nerve, like any of the nerves can get involved. So this is like the mononeuropathy. Then there is a term called as mononeuropathy uh, multiplex. Now this is something more interesting. Um, why? Because mononeuropathy multiplex is what, like, again, one nerve is involved, but why they put multiplex is because um, this defect basically involve multiple discrete nerves. Okay, so what happens is, you can say, they can destroy some small parts of the nerve, not the whole nerve. Okay, so of course, like, it is some sort of systemic condition like vasculitis or collagen vascular diseases which causes such a condition. So mononeuritis multiplex is this thing. Then there is polyneuropathy. So again, we know what is mononeuropathy and polyneuropathy, when simply one more than one of the nerves are involved. So for example, what do you think about this one? See, of course, the nerve which supplies sensations over here is different, or motor part over here is different than this one, and then this one. But see, all of these are involved. So of course, like, this is some systemic condition which is damaging nerves at some particular areas in the body. So this is an example of what? Polyneuropathy. So of course, like, this happens in diabetic patients, okay, because diabetes, they cause micro uh, angiopathic damage to the peripheral nerves and long nerves, you can say. So what happens is like there is distribute like there is decreased sensations in the gloves and stocking manner. So this is an example of polyneuropathy. uh, Now what happens is simply the legs are affected more than before than arms. Why? What's the reason behind that? Because remember, it is symmetrical, you can see over here. Okay. Why? Because the most commonly sorry the most you can say the nerves which get affected first are basically the long fibers, the longest fibers. So see, in the legs there are like long fibers are here, so they are the one which get affected, and of course then the hand, and then it proceed like in a upward going fashion. So diabetes mellitus is the most common cause of polyneuropathy. Renal diseases can cause, toxins can cause, SLE can cause, and all these things can cause. There is one more thing called as CIDP, or chronic inflammatory demyelinating polyneuropathy. What happens, as I am telling you the name, it is chronic condition, it is inflammatory condition, and it is demyelinating condition. Like there is demyelination, and it will involve many of the nerves. So that's the reason like they have this condition. And now uh, it's better to tell you how to approach a patient of polyneuropathy. Why? Because uh, like approach, I think, is more important than again going through the condition. And I will not touch sciatica, for example. You are going to study that in surgery, because uh, not just sciatica, rather there is something called as cervical spondylosis, uh, or you can say the vertebral disc herniation, because they causes pressure on the spinal cord, but they are managed surgically, and they are the topic of surgery. So I'm not going to touch them here. Rather, I will tell you the neurology topics which a neurologist deal, right? So we are going to cover them as well. So okay, before going to the approach of the patient, see, I will show you this photograph. This one is very important. See, now look at this patient. This one have the loss in which pattern? Gloves and stocking. We know it is symmetrical, and we know it is involving different nerves. So this is an example of a generalized peripheral neuropathy. One of the example I told you is diabetes mellitus. Whereas if you will see in this patient, for example, see, he have loss in sensation in C5, like over here, or C7 over here, or L5 over here. Okay, so of course, like when we have, for example, we get a patient in which like the loss is just this one, so we now know that there is some sensory root, because the loss is in the dermatomal fashion. The loss is in the dermatomal fashion, or here the loss is in the dermatomal fashion. Now we know that one of the sensory root is the one which is getting compressed. What I mean to say is, you can see I am talking about this one. This root is depressed, compressed, okay? Compressed, or whatever, like the trauma or whatever, the pathology is over here. You can see over here, if you will get a patient like this, like see, he have sensation loss from this area down, all the way down. Now uh, this one is a dorsal column lesion. This is not a peripheral nerve neuropathy, it's a central neuropathy. Why? Because see, something happened in the spinal cord, and below that level everything is lost. So upper motor neuron type of signs will be there. Again, this condition I teach you yesterday, like yesterday means like the previous lecture, I gave you transverse myelitis. So this is a patient of transverse myelitis, or simply the spinal cord is transected at certain level. Which level? Umbilicus T9 T10. This is the Brown Sequard syndrome. I think we have discussed this before. Now this one is a central cord syndrome. We had discussed this thing before. Now see, I told you the cross features are there. Right side of the body, left side of the face, brainstem lesion or a central nervous system lesion, or all of the half of the body is gone. Again, it's a CNS type of lesion in the cerebral hemisphere. So see, like again, I gave you, I'm showing you this one just to give you the direction how to think, right? And these two, of course, they are the peripheral neuropathies, and rest are all CNS conditions, central nervous system conditions, right? So now, how to approach the patient? See, uh, we have to do a lot when we. Now, I'm taking you in this way. I will tell you the causes later. Rather, I will first of all talk about, you can say, how to approach a patient. Okay, so approach to the patient. Now, see, we have to differentiate many things. If you are very good familiar with what is how the nervous system is organized and what is the function, how it functions. So, first of all, on history or examination, you have to sort out either it's a motor type of lesion versus sensory one. Either it's or versus autonomic, okay, or you can say it is mixed. Okay, simply when you will reach this conclusion, it is going to help you in a good way just to reach the point of pathology. Okay, then we see either it's symmetrical, okay, or simply you can say we see the symmetry. We see either it's focal or it's diffuse. Okay, diffuse will give us the direction that it is some sort of generalized problem. Then either its upper limb is the one which is involved or the lower limb. Okay, or you can say or cranial nerves. Okay. Other than that, if you will, when on taking history or examination, you have to see either it's acute type of condition or chronic type of condition. So uh, this will give you point towards like what. Now either it's relapsing or you can say relapsing remitting, or you can say um, okay, yes, or either it's constant or either it's progressive. Now when I will show you the causes, of course you would understand like what I'm talking about. So see, like all these things we have to sort out, and then we will uh, take the history, because when I will show you the causes, we have to ask the past medical history, uh, we have to ask the family history, we ask to about the drugs, about the exposures, okay, about the systemic symptoms we have to ask from the patient, and either like if there is any cranial which are, oh, I already talk about that. So simply like all these things we are going to see in the patients, right? Now what's the point behind this thing, why I'm stressing on this thing? Because see, first of all we have to see either it's a peripheral neuropathy or it's a central problem. For example, um, um, in most of the conditions, when you will take the history or when you will do the examination, whatever, you have to found, okay, either the sensory system is there or the motor system is there, or if the sensory system is there, either it's small fibers, either it's large fibers, either there is any negative symptoms or either there is any positive symptoms. Now see, negative symptoms means what? Like the things which you already have, like we can sense the temperature, so when it is lost, it's a negative symptom. Like something which we had normally but now it is lost. Or for example, someone had burning sensations, so which means that normally we don't have burning sensation, but someone who have burning sensation, it means that there is something addition in his body, so it means it's a positive symptom. So I'm talking like uh, now the thing is like when we ask about the burning sensation, or you can say electric type of sensations, or tingling or pins or needles, all these things, uh, we are basically looking either the problem is related to nerve or not. because these are all causes which are basically nerve related. So, like the large fiber neuropathy, which I show you over here, like the large fiber neuropathies, they present with numbness, tingling, especially you can say in the toes and in the feet, and then they started ascending in the stocking fashion, and then later on they can involve the um, you can say the hands as well. Okay, so this is the symptoms of the large fiber nerve involvement. Or when we do the science, because see, I am talking about the large nerve problems. So when you will do the examination, you will found that they have decreased vibration, decreased joint of position sense, as well as reduced reflexes. And whenever it is small fiber problem, these patients they present with uh, you can say pain and pricking or shooting type of pain. And when we do examination, we found that they have pinprick or temperature sensations are lost or decreased. Motor fibers, motor fibers, they present like cramping pains, weak grip, foot drop, twitching, and on examination we can see the strength of the muscles. And autonomic problems present with decreased or increased sweating, dry eyes, dry mouth, erectile dysfunctions, diarrhea, lightheadedness, hypotension, and things like this. Like, think about all the autonomic functions which are done in the body. So, see, now what I was where I was talking about, like we will see the pattern of the loss, right? And we will see either it's large fiber, either it's small fiber, either the motor system is involved, or either the autonomic nervous system is involved. So, for example, see, if you are founding that, okay, the problem is just in one hand, and you are founding that the problem is just in the lateral 3.5 digits. So see now, uh, the common sense says that it is some sort of nerve problem. Why? Like, I'm talking about the carpal tunnel syndrome, right? So that will give you direction in that one. So whenever the nerve peripheral neuropathy is there, most of the time the sensory symptoms they started appearing before the motor symptoms. And motor symptoms are basically they started appearing late. um, so that's like one of the thing we can appreciate while taking history in the patient. And see, diabetes basically gives, you can say, the length dependent pattern of sensory symptoms. Of course, like in that case the diagnosis is not so difficult. Why? Because we see that the legs are more affected than the hand, so it means like the long fibers or the long nerves they are affected more than the shorter one. So we will point toward it will point towards that one. So like that's how we proceed, right? And we started making things logical. uh, okay, talking about the distribution, when you will see the distribution, for example, polyneuropathy, I talk about polyneuropathy. Polyneuropathies involve widespread and symmetric dysfunction of the peripheral nerves. Okay, mononeuropathy involves, you can say, single nerve, peripheral nerve, on multiple mononeuropathy, which is also called as uh, uh, multiplex. Of course, like in that one, of course, like they are going to involve multiple peripheral nerves. Okay, mononeuropathy, like for example, this one is like carpal tunnel syndrome. These are mostly due to compression, trauma, or vascular causes. Whereas if it is multiple mononeuropathies or mononeuritis multiplex, right, which I already told you what is that. Uh, it can be due to multiple entrapments, but most of the time it is due to vasculitis or infiltration. Or I gave you the example of plexopathy, right? Plexopathy, in which like two nerve roots are gone or down one, or brachial or lumbosacral, whatever is there. Uh, it is, of course, asymmetrical. Either it will be right side or on the left side, but very rarely on both sides. Okay, so this thing. So see, what I am establishing number one, you can say, is it a peripheral neuropathy? Secondly, I am establishing what is the distribution. Thirdly, I am establishing what type of fibers are affected. And fourthly, I am establishing what is the anatomic pattern of that loss, right? And now, one of the thing which I am going to appreciate or I will see is like either the condition is acute or either the condition is chronic, or you can say what is the progression of the condition. For example, uh, we will study one condition called as Guillain-Barré syndrome, GBS. Now, GBS is an inflammatory condition, or Guillain-Barré syndrome is an inflammatory condition which occurs or which evolves rapidly. Okay, so now, for example, if there is some toxic condition of they can evolve rapidly. For example, some conditions which are evolving slowly or chronic neuropathies are there. So think about some hereditary causes, like one condition is called as Charcot-Marie-Tooth disease, in which like the nerves, of course, they get involved, but it takes some time. Okay, so simply we'll see like either the condition is acute and either the condition is chronic. So acute, think about the acute causes, think about vascular causes, think about trauma, think about toxins, think about inflammations. Chronic, think about degenerative type of conditions. And then of course our final thing is to sort out, not the final thing, but like you can say the final thing in history is to sort out what can be the most likely etiology. For example, you will ask the past family history, you will check for any diabetes, renal failure, HIV infection, Lyme disease. You will check for either the patient is taking any drugs, like HIV drugs, anti-cancer drugs, or heavy metals, or either the patient is um, like in past medical history, either the patient is a patient of any conditions like polyarteritis nodosa or Schwarz syndrome, which causes vasculitis simply. And when vasculitis is there, it can cause a problem with the nerves. So all these things, we try to establish, and then of course we go on to the investigations, and then we decide about the treatment. Now, one more thing, guys, which is I think very, very, very important. Again, before going to the causes, which I want to tell you is, uh, um, I want to show you this thing. Okay, now what is myelination. Like this is like the nerve fibers or the axons, they are covered by a white matter that is called as myelin sheath, right? And then there is axons, right? And then there is like neurons simply. So now we when we take the history, we also uh, try to grab the points which will point towards either the condition is a demyelinating type of disorder like multiple sclerosis. But multiple sclerosis, of course, central condition, central nervous system condition. So, for example, yes, CIDP, like or chronic inflammatory demyelinating polyneuropathy, or diabetes mellitus is like it causes demyelination. Diabetes mellitus, by the way, it causes damage to the myelin sheath as well as axon both. So you can say it is. So GBS or Guillain-Barré syndrome is a very good example of this thing, a demyelinating type of disorder in which the myelin sheath is the one which is affected. Then there are certain conditions which basically damage the axons. Okay, so when the axonal damage is there, the presentation is little different. For example, the things which can cause damage to the axons are toxins, metabolic conditions, and HIV also. And then there is neuronal type of damage. Now, why I'm talking about this thing? Because uh, whenever it is demyelinating type of condition, most of the time it is acute or subacute, whereas axonal is basically slowly evolving type of condition, whereas neuronal is rapid. And demyelinating type of condition, damages proximal axial as well as distal nerves equally, whereas axonal damage basically damages more of the distal nerves than proximal. So simply, axonal is a length dependent type of damage, you can say. Now, a very, very, very important thing, guys. In demyelinating type of damage, there is weakness and paresthesia. Okay, um, but in axonal type of damage, the weakness is mostly distal. And when it comes to the sensory signs, demyelinating type of condition damage more of vibration and proprioception than pain and temperature. So that's why whenever there is demyelinating type of condition, the vibration and proprioception will be affected more than pain or temperature. Whereas axonal type of damage, or you can say give damage to the small fibers, or you can say the pain and temperature sensation are affected more than the vibration and proprioception. So this is very, very, very important thing. And of course, like we can um, diagnose them nowadays by the help of something called as nerve conduction studies. Okay. Now, demyelinating type of conditions, the recovery is instant and good. Axonal type of damage, there is slow recovery from them. Okay. So this is very important few points which I wanted to talk about before going on to the causes. Now, the causes of peripheral neuropathies. You can see over here. This is the etiology, this is the mechanism, this is the course, and this is the modalities. So you can say S is for sensory and M is for motor. Okay, and A is for autonomic. And if you will pay attention, see what are the causes of peripheral neuropathy. Vascular causes are there, infectious causes are there, immune causes are there, hereditary conditions are there, neoplastic causes are there, toxins can cause, metabolic conditions can cause, nutritional deficiencies can cause, and other things are also there. So what are the vascular problems? Polyarteritis nodosa, it causes vasculitis, causes damage to the nerves. So see, mechanism is ischemic, exemic. Infections, HIV causes axonal as well as demyelination. So see, like this one, diabetes will cause ischemic as well as axonal damage, and the course is chronic. So if you will pay attention over here, you will see that there are different causes, and of course, in the history, we have to cover each and one of them. Like if we, it's hard. Sometimes it's hard to make the diagnosis. So rheumatoid arthritis and systemic lupus erythematosus. HIV can cause leprosy, Lyme disease, Guillain-Barré syndrome, which we are going to study. It's a demyelinating type of condition. It's an acute condition, and it affects mostly motor nerves. CIDP, or chronic inflammatory demyelinating polyneuropathy. Then many of the paraneoplastic syndromes can cause toxins like ethanol, alcohol damages axons. Heavy metals like lead damages axon. Medications damage axons. Whereas diabetes mellitus give ischemic as well as axonal damage. Hypothyroidism give axonal damage. Renal failure give axonal damage. Porphyria give axonal damage, and amyloidosis give axonal damage as well. So uh, these are all the causes of peripheral neuropathies, and of course, like uh, that's how we approach the patients. As I told you, we ask all these questions. There are classification in the books, classification according to the, for example, what are the causes of small fiber sensory loss, what are the causes of large fiber sensory loss, things like this. Okay, or what are the common causes of motor neuropathies or autonomic neuropathies. These kind of things. Kind of classifications are also there. Or the classification can also be done by on the basis of acute, subacute, chronic. For example, Guillain-Barré syndrome is an example of acute uh, peripheral neuropathy. Um, Toxins or nutritional causes are the causes of subacute one. And diabetes, for example, is an example of chronic or CIDP, or chronic inflammatory demyelinating polyneuropathy is the cause of chronic. So see, you can classify on the basis of this thing, uh, on the basis of mechanism, on the basis of course, or on the basis of modalities. Because see, you can see there are some which are purely motor, like Lyme disease affect motor fibers, or amyloidosis affect sensory fibers, and many of them they are mixed as well. So, uh, like of course, like these things uh, are important. So once we know the causes of all the polyneuropathies, uh, I think it will be easy for you what investigations you can do in the case of peripheral neuropathies, right? Of course, when it is too much causes, talking about the investigations become hard. So, multiple serologies, history give you a lot of points, number one. Number second, examination give you a lot of point. Number third, you can confirm your diagnosis. Serologies, HIV, nerve biopsy, Lyme serology, lumbar puncture. In the cases of hereditary disease, you will do genetic testing. You can check for paraneoplastic antibodies, and you can say you can do serum protein electrophoresis in cases of myeloma or lymphoma or monoclonal gammopathy. Glucose tolerance test you can do, urine for heavy metals you can do in case of lead poisoning, drug levels you can check in case of medications, fasting glucose or HbA1c in case of diabetes, thyroid function test. And so see, because the causes are too much, so the testings are too much, right? So of course, uh, these are just to catch what you can say, what are the causes of neuropathies, right? Now, okay, the important thing over here, which I'm going to discuss, is what is the treatment of peripheral neuropathy, right? Now, to tell you, for example, do you think there will be any treatment for Charcot-Marie or hereditary motor sensory neuropathy? Of course, it's a hereditary condition. So, when you will study this condition, of course, you can know the treatment of that particular condition, right? But what I mean to say, uh, what you must do in case of diabetes mellitus, of course you have to treat diabetes. Or what you can do in the case of hypothyroidism, of course treat hypothyroidism. Or what we can do in the case of beta vitamin B12 deficiency, of course treat that. So of course, like, treatment of this thing is simply uh, treatment of the underlying cause, okay? Or what is the treatment of, for example, toxic neuropathy? So of course you have to remove the toxic substance, which is the most important step, okay? And whenever it is, for example, heavy metal like lead, okay, so we do a chelation therapy, like we can give them penicillin or calcium EDTA for lead toxicity, things like this, okay? If, for example, there is other toxicities, we can give them, in alcohol we give them niacin and pyridoxine, okay? Simply just to reverse them, like many of the things they are reversible, many of the things they are not reversible, of course. But I'm just telling you, uh, because there are too many causes, so we and too many conditions which are basically belong to different parts of internal medicine. So treat the underlying cause, that's why can be one of the thing. So of course, like, you guys had done diabetes mellitus. So how we treat diabetes mellitus, we uh, try to control the glucose, okay? And when we keep the glucose levels in the ideal, you can say, uh, range, it decreases the progression of that loss simply. So this is like how we treat the things, right? And of course, for example, talking about carpal tunnel syndrome or talking about sciatica, or talking about any type of nerve entrapments, what is the treatment? Of course, treatment is surgeries, right? So, but let me tell you one very important thing before going to Guillain-Barré syndrome is whenever there is any neuropathic pain or the pain due to nerve problems or neuropathy pains, we give them drugs like wait. Okay, so you can say the drugs or drugs for painful neuropathies. Okay, what are those drugs which we can use? Remember, tricyclic antidepressants can be given, like amitriptyline, nortriptyline, imipramine, drugs like this. We can also go give serotonin and non-adrenaline reuptake inhibitors like venlafaxine. We can give them carbamazepine. We can give them valproic acid. We can give them, these are considered as first line drugs, gabapentin or pregabalin. Now, guys, like there are many other drugs, and these are considered as first line drugs. There are more drugs other than this as well. Of course, like I'm not writing all the list over here, but other than these, of course, like there are many other drug groups as well, and these are considered as the first line drugs. And then, like sometimes when the pain is out of control, we can give uh, opioids like methadone, morphine, tramadol, drugs like this, or you can say topical drugs like lidocaine can be used, or levodopa, things like this can be used. So whenever like there is painful neuropathies, we go to treat with these kind of medications. Okay, so this is about the peripheral neuropathies. And one of a very short topic which we are going to include in this lecture is called as Guillain-Barré syndrome. Uh, Rather, I should add over here as well uh, the Guillain-Barré syndrome. So this is the one which is called as basically GBS. Okay, so we are going to cover this topic as well. Okay, so now, what is Guillain-Barré syndrome is uh, basically this one is uh, sometimes very fatal type of condition, which can which have serious consequences. It is also called as AIDP, or acute inflammatory demyelinating polyradiculoneuropathies. So Guillain-Barré syndrome, remember guys, it's an acute, uh, can be very severe uh, polyradiculoneuropathy, which is immune mediated or which is autoimmune in nature. So that is the definition of this thing. And acute, rapidly involving, rapidly evolving, demyelinating, inflammatory polyradiculoneuropathy. So it's an acute, immune mediated, rapidly evolving, demyelinating polyradiculoneuropathy. Okay, this is the condition which basically starts in the distal limbs and then it ascends upward. Okay, so you can say the distal lower limbs and then it ascends upper towards the body. So now, uh, if you can see over here, what I show you here, infections or immune GBS, see, motor, it is acute, it is demyelinating, and it affects mostly motor fibers, right? So that's very important point. So now, what's the important thing over here to cover is wait. Okay, so now uh, talking about the etiology first of all, of course it's autoimmune or your immunity which attack your peripheral nerve myelin sheath, and sometimes it is preceded by a viral or bacterial infection. So you can say that in some of the patients we can find a history of viral bacterial infection, and the common pathogens which are involved is Campylobacter jejuni, CMV, Epstein-Barr virus, or like any infection from this thing. Later on they can have this thing. So see, half to two-thirds of the GPS patients report symptoms of a respiratory tract or GIT infection within a month to a week preceding neurological symptoms. And of course, like I would not go in too much detail of this thing, but it's autoimmune condition. So of course, like there will be T cell activation, and they will be directed uh, antibodies against the myelin sheath to the peripheral nerves, and simply they are going to destroy that, and that's the result. When that will be involved or that will be destroyed, then there will be what you can say demyelinating type of nerve involvement will be there. So now you can see over here a very 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 nice photograph. See, like this is the axon and this is the myelin sheath. So see what happens in this one is, in this one, like this is the myelin sheath in the healthy individual, and this one is, you can see there is demyelination is going on and there is inflammation because there is damage to the sheath is there, right? So axonal degeneration may be present, but not in most patients, and all levels of peripheral nervous system are involved, with multiple foci of inflammation scattered from spinal roots and ganglia to the terminal motor nerves, and also cranial nerves and sympathetic chains and ganglia. So, talking about the clinical features, guys, now uh, it mostly involves the motor, but it do involve the sensory nerve systems. Nerve problems as well. Okay, so, and by the way, there are many subtypes of Guillain-Barré syndrome. So what happened in these patients when they have this Guillain-Barré syndrome? They have evolving areflexic motor paralysis with or without sensory disturbance. So there could be sensory disturbance. So see, there is complete areflexia, which is common and found in 80% of the patients, right? And there is motor weakness, okay, and which is symmetrical, which affect the lower limb first, and it started ascending to the upper body. And uh, it can involve the cranial nerve, often bilateral, okay. In two-thirds of the patient, most commonly facial nerve, but other nerves can also be involved. uh, Now the important thing, why we are feared of this thing, because this one can affect the respiratory muscles. So when it keep on ascending and it affect the respiratory muscles, what will happen, that the patient can go into respiratory paralysis, right? So the weakness typically start within an hour to few days, and many of the patients, they do complain of tingling sensations, and uh, the lower cranial nerves are frequently involved. For example, the lower cranial nerve, they are the one which by which we speak, we eat. So they have bulbar weakness simply, and when the it is going to affect the respiratory muscles, of course, the patient will need some ventilatory assistance. Otherwise, of course, there will be respiratory failure and the patient can die. So this is very, very, very important thing, you must remember. Bladder dysfunction can occur as well, okay, uh, uh, in severe cases, okay, but it is like short-lived. But uh, and autonomic involvement is also common, um, but the most common thing which I told you already is the motor one, you have to remember, right? So simply sensory involvement can be there, motor involvement can be there. It is ascending type of paralysis, and uh, it can cause autonomic problems as well. So I already talk about these things, right? I am just scrolling it down if you want to read something. By the way, they may have mistakes, but like like these are the autonomic manifestations, which could be any blood pressure problems or labile blood pressure, The patient can have hypertension or hypotension. Okay, arrhythmias can occur, sweating can occur, bladder dysfunctions can occur. So this thing. Now, guys, um, diagnosis. I will explain you. This is like again the explanation of the same things which we have already discussed. So these are the features strongly supportive for diagnosis. Asymmetry, sorry, symmetry, mild sensory involvement, uh, rapid progression of weakness, which has ceased by 4 weeks, and recovery usually begins in 2 to 4 weeks after progression stops. And features that rule out the diagnosis, like weakness of limbs, are obviously and persistently asymmetrical. Think about other causes. Okay, or obvious plane of sensory loss. Think about other causes. Sweat dysfunction of mixture, like when the bladder is very much involved. Think about other conditions. Okay, and then there are many GBS variants as well. For example, one thing is called as acute motor axonal neuropathy. Now this one is more common in children and young adults, and it is more prevalent in China and Mexico. And it may be seasonal, and they have anti-GD1A antibodies in these patients. And this one is basically they damage the axons. So this thing is one of the variant, and see, axons is obviously affected in this one. Then there is Miller-Fisher syndrome, MFS. Again, this one can affect adults and children. It is uncommon type, and it causes ophthalmoplegia. This is the important thing. Okay, it causes ataxia. It causes areflexia as well. And in these patients, we found anti-GQ1B antibodies. Okay, uh, so it is not so common variant, by the way. There is one more variant called as AMSAN, which is acute motor sensory axonal neuropathy, which is again a axonal type of damage. So that is there. Okay, guys. So talking about the investigations of these patients. Now, how we examine these patients, or how we diagnose simply. So of course, like the clinical history, examination will help you. In investigations, few of the investigations are needed. CSF testing, they have high protein and normal WBCs. Okay, uh, they have something called as cytoalbuminic dissociation. Why? Because they have increased level of, you can say, uh, monoclonal IgG antibodies in them. So that's why they have cytoalbuminic dissociation. So we can take the CSF, in which like we will found that they have normal white blood cells, but the proteins count, it can be raised. And CSF protein is increased in 80 to 90% of cases and often normal in the first week of onset, right? Like these are like the details of that thing. Rest we can do nerve conduction studies as well as electromyographic studies. So of course in that one you will found that motor fibers are involved more than sensory. There is slowing of the nerve conduction, and all those things are there in these patients. So uh, CSF findings are very important. Okay, elevated CSF protein level, and white blood cells will be normal. Okay, so this thing is like the important thing to remember in these patients. Okay, there is what you can say a diagnostic criteria of GBS as well, in which what you can say the patients. This is like about the electrodiagnostic studies. Okay, so we can do this thing. We can do that one. And differential diagnosis, of course, will be a lot in these patients, uh, like poliomyelitis, myasthenia gravis, acute myelitis, hypokalemic periodic paralysis, and other polyneuropathies. Of course, like so, there is a diagnostic criteria for Guillain-Barré syndrome as well, in which, like they say, anyone who have progressive weakness of two or more limbs with areflexia and the disease course is less than 4 weeks, and you have excluded all the other conditions, so that strongly suggests that the patient have Guillain-Barré syndrome. When it comes to the treatment, guys, now the treatment is simply uh, what you can say, um, we give, because see, it's a autoimmune type of condition, right? So see, if I will tell you the shortest version of treatment, it would be giving the patient intravenous immunoglobulin, or you can say plasmapheresis, which we do in all the autoimmune type of conditions. We have to manage the pain. We have to monitor the vitals, because there is autonomic instability. And one of a very important thing, like the patient in which respiratory system is getting involved, we can do vital capacity monitoring. So this thing is important thing. But to tell you in detail, like most of the patients, they require hospitalization. Okay, so um, why? Because each day count. Around 2 weeks after the first symptoms they appear, immunotherapy is no longer effective. So what we give to them is uh, high dose of intravenous immunoglobulins. Okay, so this is very, very, very effective therapy. And um, this one is like the initial therapy which we give, and it have a good safety record. And if of course needed, we can go for plasmapheresis. Okay, so plasmapheresis, um, of course, should be done if intravenous immunoglobulins are not working. And this is like, of course, the details, like how plasmapheresis can be done and how much is needed. You don't have to remember the dosages. That's a good part, being a medical student. So by the way, we do around 4 times over a week, 4 to 5 sessions over here, written over here. Okay. Of course, like if the patient needed, what you can say, um, for example, if the patient is going into respiratory failure, what you will do? Mechanical ventilation. Okay, so at this point, mechanical ventilation for respiratory compromise. Okay, so of course, like we are going to put them on mechanical ventilation. So what they do, like they keep on checking the vital capacity. If it is decreasing, so it means like the patient is needed uh, mechanical ventilation. Glucocorticoids or steroids are not found to be effective in GPS. Sometimes the people who have very mild condition, we can give them this thing. So of course, like if the patient is worsening, uh, we admit them in the hospitals. We check we keep on monitoring their blood pressure, their vitals, their heart rhythm, because arrhythmias can occur. Deep vein thrombosis prophylaxis should be given, and chest physiotherapy should be done. Uh, ICU can be they can move to the ICUs, of course, like if needed. So these are the things. Talking about the prognosis of the condition, guys, there are bad prognostic factors. There are good prognostic factors, but in simple words, 85% of the patients, they they had full functional recovery within months to a year. Okay, so simply the peak of the symptoms they reach in 2 to 3 weeks, and you can say the resolution occurs within 4 to 6 weeks, and there is 5% mortality, especially related to those patients who are admitted into the ICU. 80% of the patients they recover, and 15% of the patients they do recover, but with some neurological deficit. Okay, so this is very important, right? So prognosis: 80% recover, 5% mortality, 15% have some minor deficits. Okay, so thank you so much, guys. One point which I'm mentioning you in the end, but there is a reason behind that. It's a very favorite question of PLAB and different exams. The most common infection in GBS, like, or which is preceded with GBS, is called as Campylobacter jejuni. It's by Campylobacter jejuni. So in most of the patients, when you will get a question like this, that a patient presented with weakness, like things like this, and he was having Campylobacter jejuni infection before. So remember, it is GBS. And GBS is a neurological emergency because of respiratory failure. So thank you so much for listening, guys. I will see you in the next lecture.